Good evening, everyone, and welcome. I'm Tony Segreto, and once again, pleased and so honored to be your moderator for another dynamic In the Know town hall. Once again, as most of you know, if not all of you, this is our chance to candidly engage with some of the brightest medical minds at UHealth on a topic of great importance. And tonight, we're talking about breast cancer survivorship, which is especially significant as we commemorate Breast Cancer Awareness Month. Now, we often talk about detection and treatment options for breast cancer from the first diagnosis to the final treatment. But here's the question. What about the ongoing monitoring, the support, and the care survivors need after this initial cycle? I think you're going to hear quite often tonight, surviving breast cancer is not a one and done deal. This is a lifelong journey. Treatments can have debilitating and chronic side effects. Survivors endure many unique medical and psychosocial concerns well after their primary treatment. As we stand here today on October the 27th, 1 out of 8 women in the United States is diagnosed with breast cancer. Now, you have to admit, those numbers are staggering. And as of January 2022, there are more than 3.8 million breast cancer survivors in the United States. Now, based on those numbers alone and going forward, expanding and improving lifelong interventions and programs for survivors, their families, and caregivers it's imperative that it becomes a healthcare priority. Tonight's panelists approach breast cancer survivorship from every angle, from surveillance recurrence and second cancers to important psychosocial support services. Now, before I introduce our panelists tonight, I want to point out a small but very special departure from our usual format. While we will engage with our experts to answer your questions on all aspects of breast cancer survivorship, we are truly fortunate to have a Sylvester patient with us tonight who will elevate our understanding of this life-changing disease. I welcome Patricia Gaynor to our town hall. Patricia had the pleasure of meeting with Jill Biden during the First Lady's recent visit to Sylvester, and we are pleased to be able to share her extraordinary journey tonight. Patricia, I can't even tell you how honored we are to have you here and have us better understand what is required for long-term recovery and healing. And we look forward to hearing from you just a little bit later. Now, alongside Patricia is our team of outstanding Sylvester physician scientists, led by Dr. Susan Kesmedal. She's the director of the Breast Surgery Oncology, co-leader of the B-Site Disease Group, medical director of preoperative services at Sylvester. She's also the associate professor of surgery in the Division of Surgical Oncology at the Miller School's DeWitt Daughtry Family Department Surgery. Now, Dr. Kesmedal also has a recent claim to fame. Last Saturday, she was live on Good Morning America, sharing her journey to serve breast cancer patients. Also with us tonight is Dr. Alejandra Perez. She's the medical director of the Bremen Family Breast Cancer Institute in Sylvester in Plantation. She's also the associate professor of medicine in the Division of Hematology and Oncology at the Miller School. And Dr. Patricia Moreno. She leads the evidence-based survivorship supportive group and that care program at Sylvester. She's also the assistant professor in the Department of Public Health Sciences and Department of Psychology at the Miller School. Needless to say, we are extremely fortunate and so blessed to have this wealth of knowledge, expertise, and most importantly, the life experiences to be with us tonight. Now, before we get started, we're going to go over how you can participate in tonight's conversation. You'll have the opportunity to submit questions during this program live. For those of you who have been with us before, you know the drill. For those of you who are new, it's really simple. You see at the bottom of your screen, there's a Q&A feature. Use that to send us your questions. We want to tell you that every question submitted is anonymous, and we really promise, we'll get to as many of them as we possibly can. Now, some of you who have already submitted questions. They're fantastic. So let's get going with our very first one of the night. And Patricia Gaynor, you get to lead us off. We are so, like I said, so happy to have you with us. So here's your question. What did you discuss with the First Lady?
I discussed my journey with the First Lady. I explained to her when I was initially diagnosed with the breast cancer, when my cancer reoccurred, and basically that I continued to work. And when I had the photo with the First Lady, I jockeyed for a seat on Air Force Two.
Very nice. That's not a bad way to start your day. Dr. Moreno, our next question is for you. We welcome you tonight. Thank you so much for taking the time. What is survivorship and who is considered a survivor?
Thank you so much, Tony. It's lovely to be with everyone. You are considered a survivor from the moment you receive a cancer diagnosis. That's not always the way the term is used. Sometimes people use it to describe someone who has finished cancer treatment, but anyone who has received a cancer diagnosis is considered a survivor. And of course, there's lots of differences in between people who are in treatment, those who have finished treatment, and those who will be on continuous treatment through life. And so the focus of cancer survivorship is to really improve the health of anyone who has had a cancer diagnosis and to improve their quality of life. So the idea here is that there's a lot of management, like you mentioned, Tony, in the beginning, of the effects of the treatment of cancer, which can affect the body and cause symptoms that can impact quality of life. So cancer survivorship is all about keeping you living as well as possible after cancer.
Thank you, Dr. Marina. I know that later in this broadcast, we'll be talking about some of those effects that women go through. Dr. Perez, we welcome you. It's so nice to have you with us tonight. I know all of you are so busy. Your question goes like this: can breast cancer go down in stage?
Yes, in some cases. So when you have stage 4 or metastatic breast cancer, you stay at stage 4. And staging is important because we know how to treat patients based on that. So, but if you have a patient, let's say, that presents with stage 3, let's say it's a patient that has a large mass in the breast or maybe positive lymph nodes, if we give chemotherapy to that patient, we can downstage the patient, meaning the tumor mass can decrease significantly. Maybe the lymph nodes will go from positive to negative. So in some cases, we can downstage the patient.
Great, thank you so much. Dr. Kesbadal, welcome. And you're a pro at this after being on Good Morning America. So what advancements have been made in the surgical management of breast cancer?
So I think we've made so many strides in treating breast cancer in the last 30 years. And from a surgical standpoint, one of the best things is that we're able to do smaller surgeries. And by doing smaller surgeries, we can actually reduce the long-term complications that women have from breast cancer surgery. As Dr. Perez just mentioned, we more frequently now will give patients upfront chemotherapy. This allows us to reduce the size of the tumor. It can also allow us to reduce the involvement of the lymph nodes. So before, when we might have to do a mastectomy on a patient and remove a lot of lymph nodes, now we can do a small procedure on a patient, do a lumpectomy, take out fewer lymph nodes. And the end result is that many women can preserve their breasts if they want to. And we also, by reducing the number of lymph nodes we take out, we can reduce the risk of arm swelling, which is a major complication from lymph node surgery and is a lifelong problem that women have.
Thank you, Dr. Kesbadal. Trish, we're going to come back to you, and I wonder if you could be kind enough to really pull the curtain back for us. What was the feeling like when you first learned you were diagnosed?
I was in shock. I have no family history. So it caught me by surprise.
Was it, sometimes women portray it as a gut punch, as just like, you feel like, okay, the bottom's just dropped out. How with the doctors, especially at UHealth and Sylvester, how did they get you through that initial moment of the diagnosis?
The doctors were wonderful. All of my questions were answered, and I felt that I was definitely in the right place. And I felt, for lack of a better word, I felt protected.
That's pretty strong to be feeling that way, especially with that kind of diagnosis. Dr. Moreno, what areas does survivorship cover? I mean, when we think of someone surviving, we think, well, once they get through this, they're done, but this is an ongoing process. So what areas does survivorship really cover? I have to believe there's a multitude of different areas.
Yeah, absolutely, Tony. So a cancer diagnosis and treatment has long-lasting effects, like and on the whole person, right? So survivorship covers, of course, physical health. So symptoms like anxiety, pain, fatigue, whole body wellness, cardiovascular health, things like that. But also emotional well-being, right? Anxiety, impact on mood. I think when you receive a cancer diagnosis and really important identities or roles that you have in your life are disrupted, that can impact you, and not just during the treatment. Oftentimes, individuals will say that when they finish treatment, if they do have a sort of post-treatment phase, it's that moment where they pick up their heads and really think, wow, what did I just go through? You know, they sort of soldier through the process of treatment, and then afterwards are left feeling really raw and like they need a lot of support. So emotional well-being is huge. Social well-being, of course, is important because our relationships define us and really determine our quality of life in a lot of ways. And the impact on your body and the impact on your sort of spirit and mind and emotional well-being also trickles down into your relationships with other people. And all of those things, you know, the physical health aspect, the emotional well-being aspect, the impact on social relationships, all end up impacting sort of your ability to get through day to day and do activities that are important to you, including work, spending time with family, et cetera. And so your functional status or your ability to get through day to day activities can also be affected. And so survivorship covers all of those areas and has different sort of specialists to focus on different aspects of your well-being, and depending on what is sort of potentially driving any given symptom or concern that you have.
I have to believe the psychological part is just as important, maybe sometimes more important than just the physical.
Absolutely. Like you said, having cancer is a punch in the gut, and its impact can be devastating. And the beauty of being human is that we are also different, and you know, responses look very differently across different people, regardless of sort of their medical status, right? And so, of course, physicians see that all the time, that certain individuals cope in certain ways and others cope in other ways. But we do know that if someone is experiencing a lot of distress or they're in a lot of emotional pain, that can get in the way of their ability to get the best treatments, because it's hard to get through anything when you're in a lot of emotional pain. And so the psychological experience, we want to make sure that you get the very best medical care always, no matter what. We always want you to get the best treatments and have the best options available to you. We also want you to feel as well as possible emotionally and feel supported and feel as well as possible psychologically while you go through your experience and after the experience.
Great. Thank you, Dr. Moreno. Dr. Perez, this just came into us. I am a recent breast cancer survivor, and I'm taking letrozole. I recently found out I have to take statins for plaque in my carotid arteries. Will I be able to take both medicines with effective results?
Yes, there's no contraindication in taking both medicines. We have to make sure, we have to look at side effects, because sometimes with letrozole, you can have joint aches, muscle aches. Sometimes about 10–15% of women have some pain. And with statins, we see the same thing. So sometimes it's too much in terms of side effects, but if you're not having any side effects, there's really no contraindication. We know that cardiac disease is a big risk for women, and more women die of cardiac disease than breast cancer, for example. So we need to make sure we address both. They're equally important. And yes, it is okay to take them both as long as you're not having side effects. But we always have options. If there's side effects, we always have options to manage.
Excellent. Thank you so much. Dr. Kesmadal, you touched on this a moment ago, but again, we want to see if we can drill down a little bit. In patients who have had lymph nodes removed from breast cancer, what factors increase the risk of lymphedema, and what are the latest options for that management?
So we know that a lot of our treatments obviously have an impact on the risk of lymphedema. So it's a combination of the number of lymph nodes that are removed, the type of chemotherapy that is given. So taxane chemotherapy is associated with an increased risk of lymphedema, as well as radiation therapy. So all of our treatments impact that risk. We also know that larger women are at a higher risk for developing lymphedema. And then after surgery, many women will ask me, can I use this arm again? Can I get a blood pressure in this arm? Can someone put an IV in this arm? And we don't really have good information actually on whether that's going to increase your risk of lymphedema. Lots of people pass it down that you shouldn't have an IV, you shouldn't have a blood draw. Really, the main risk of developing lymphedema besides our treatments is if you get an infection in the arm. So we know that infection in the arm increases risk of lymphedema. So I don't like to have people have a long-term IV in the arm since that increases risk, but a single blood draw, if it's necessary to use that arm, is fine. I always tell patients, if you're able to use the other arm to get blood draws or blood pressures, I would prefer that you use the other arm. So really it's our treatments, and if you get an infection in the arm, those are the things that increase risk. We have a lot of preventative measures that we can utilize now. We have preventative surgery. So sometimes when we're taking lymph nodes out during surgery, we can actually try and preserve the lymphatics draining from the arm, which reduces risk of arm swelling. These are newer techniques that have been explored for the last 10 to 15 years. And then we have microvascular surgeons. We have the luxury of having just fantastic plastic surgeons and microvascular surgeons here. And they're doing even more advanced techniques where they can actually transfer lymph nodes to the affected arm, and that will actually reduce lymphedema. So again, the benefit of reducing our surgical interventions is that fewer women are having to experience lymphedema. There are still probably about 15 to 20% of women that are getting more lymph nodes removed. And those are the women where we're really trying to employ some of these preventative surgeries or interventional surgeries when lymphedema does develop.
It's remarkable, the advances that we've made. Patricia, what advice would you give to a woman who is newly diagnosed and is about to start treatment?
My advice would be to definitely ask all of the doctor all of the questions they have, but to maintain a positive attitude, and that is very important. To not allow the cancer to control your mind, but to try to keep it in perspective, to know that you're at the beginning. And like I said, it's important to keep a positive aspect, and also to discuss it with your family and have your family support you.
It can't be easy to have that positive outlook and not have the cancer take over. That has to be a real will of the mind to overcome that.
I think it is, but it is possible because, I mean, that's my story. I do it every day. The hardest thing for me was telling my family. Once I told my family, I made a decision that I wanted to, handle the cancer with grace and dignity. And I can't allow it to control me.
God bless you. What a great way to put it. Dr. Perez, this came in for you. What is the best treatment for recurrent breast cancer, but now is triple negative in skin?
Okay, so that's a big question, not knowing all the details of the case. But in general, yeah, we have to look at what kind of treatment the patient had before, if the patient had chemotherapy, radiation, and why the cancer changed. So it sounds like this cancer had different characteristics before. If the cancer came back on treatment that was given recently. So there are a lot of factors, of course. It's hard to make an assessment just with the little information we have right now. You have to look at the staging. If the cancer went somewhere else, if the cancer is localized to the breast, to the axilla, you have to look into what's appropriate if you need to do surgery first, or if you need to do chemotherapy first to try to shrink the tumor. And again, there are many factors that play a role, but the important thing is that many of these cases are still curable, and we always go for cure. And again, chemotherapy, radiation, targeted therapy, a clinical trial, it all depends on the case. There are very, very specific markers and things that we look at the tumor that will make us go one way or the other.
Thank you, Dr. Perez. Dr. Kesmadal, this just came in. I had bilateral mastectomy and lymph node dissection, stage 2, at Jackson 30 plus years ago. I have mild lymphedema. I now live on the West Coast and have problems getting vaccines in thigh instead of my arms. Ditto for blood test from my foot. Very hard to arrange here. Is it still necessary to avoid using my arms for the above?
So if I understand correctly, you had lymph node removal on both sides in the arm. If you had lymph node removal in both sides, it really depends on the extent of lymph node removal. It's always preferable if you already have some lymphedema, it is preferable to try not to use the arm for too many blood draws, only because of the risk of infection. So if, however, you're not able to do blood draws from other sites, then I think the best option is to use the hands. And again, not to place an IV for a long period of time. That would be my recommendation.
Okay, very good. Thank you so much. Dr. Moreno, what are the basic strategies that survivors can implement to improve quality of life?
It really depends on each person's journey and what might be particularly challenging to them or what they might be struggling with. But we do know in general, there's a few things that sort of across the board help with quality of life. One of the most important things, which I think Trish has already underlined, is the ability to communicate what your experience is, if you have concerns, if you have symptoms, with your team. So with your oncologist, with your surgeon, and that's really important because I think sometimes patients are really motivated to get the best treatments and they want the treatments to work. And so they are worried about mentioning side effects because they don't want anyone to stop the treatment or change the treatment. But it's really important to have open communication, because oftentimes there are strategies that can be implemented to manage those side effects for you to continue to be able to tolerate the treatment. And also important to mention to your oncologist if you're having other quality of life concerns, like things regarding emotional well-being, your mood, anxiety, if you're having a hard time figuring out how to talk to your family, even though that might not be something that they are going to personally spend, many hours with you navigating, they certainly know the resources of where someone who focuses on that aspect of your journey is and can connect you to the right people. And it's helpful for them to just know what is going on in general anyways, because they are quarterbacking your treatment and are guiding you through it. So communication with your team, social support is crucial. We know that women, men, individuals who have breast cancer who feel like they have support around them tend to do much better. We also know that many of our loved ones, although very well-intentioned, sometimes can miss the mark a little bit with the sorts of messages they give us or the kind of advice they try to give. And so it oftentimes takes the patient shaping or the survivor shaping their loved ones to offer the kind of support that she or he needs. And that can be done through conversation. It can also be sort of guided by someone like a social worker or a psychologist. And so, but we do know that ultimately feeling supported and feeling like you have someone who can help you through the journey and hold space for whatever experiences you're having emotionally ends up making a big difference in terms of quality of life. And then, of course, there are things like making sure you're gently exercising as much as possible, trying to do things that are relaxing. And then I would also underline that cancer has a way of showing us what is important and what our priorities are, even in the midst of oftentimes causing a lot of upheaval in our lives or challenging us, including emotionally. And so I would say it's really important as much as possible to stay connected to the things that matter to you, so that you can feel like you are doing things that are important and that make you feel like you, even if you have to kind of redefine how you do those things based on the new challenges you're facing. And that, staying connected to your values is really important for overall sort of well-being and quality of life. And again, if you are needing a little bit of support or help with any of these parts of your survivorship experience, there are always sort of psychosocial support resources, including social workers and psychologists who are available to help you.
Thank you, Dr. Moreno. Listen, I'm going to go off script for a minute. Trish, I saw you nodding and smiling during Dr. Moreno's answer. I have to believe your family support and everything she said, because when someone gets cancer, it impacts the entire family. Can you just weigh in on that? I noticed your smile and your nodding of the head as she was giving the answer.
I was agreeing with everything that she had to say. I mean, in reference to the team, in reference to the family, because of course, yes, the family will have ideas of how to help you, and it is important to verbalize basically what you need, so that your family knows how to help.
Dr. Moreno, I'm sure you'll agree.
I think Trish is such a beautiful example of staying connected to the things that are important. When she spoke to the First Lady, I had the privilege of listening, and she was telling her about the ways in which she lives a full life, even in the midst of getting her treatment and having to sort of cope with a landscape that can sometimes throw a curveball, and does it with the grace and the dignity that she values and aspires to. And so absolutely, I think it can feel sometimes like cancer can eat up all of your time between the appointments and the information and calling the insurance companies and everything else. It is a full-time job, and it can feel like there's very little space at the margins of it to live fully. And I think that one of the most important things to do is to really fight for that, so that you can feel like you are a person first before the word cancer even gets in there in terms of identity. And Trish is a shining example of that, of course.
How beautifully said. And Trish, you just radiate beauty. So we'll continue to get back to you, but I had to share that moment because I know that what Dr. Moreno said was so important to you, and so hit you home really hard. So Dr. Perez, we're going to bring you back in because we just had this sent in for you. Have there been studies done regarding a lesser dose of tamoxifen that is still effective and safer?
Yes, we've done studies. So standard of care continues to be 20 milligrams of tamoxifen once. But we know tamoxifen has some side effects. So of course we've looked at lower doses of tamoxifen. So there are studies looking at 10 milligrams every other day or 5 milligrams daily. And there's mainly one study that was well conducted, and we reference that study when discussing these indications with patients. So it is effective, not for everybody. Obviously, it depends on the case. It depends on the stage of the patient. It depends if tamoxifen is given as what we call chemoprevention, or patients that don't have cancer that are at high risk of developing breast cancer. Sometimes we give tamoxifen to decrease the risk, or if it's given for cancer therapy. So something that you can discuss with your physician. But yeah, we do have some data with lower doses of tamoxifen.
Great, thank you so much. Dr. Kesmadal, this was just sent in as well. I had 4 lymph nodes removed in 2008. Why has my arm never swollen?
So over time, we've developed less invasive lymphatic procedures. In the past, 25 years ago, every woman with a breast cancer diagnosis just had lymph nodes taken out, typically 10 to 15 lymph nodes. Now we've developed a procedure where we can identify a few lymph nodes to take out. That's called sentinel lymph node biopsy. And in those cases, we typically take out 2 to 3 lymph nodes. And of course, with fewer lymph nodes removed, your risk of getting lymphedema is lower. So this is a significant advance that we've made, which has really reduced the lymphedema rate. So in a woman who only has 4 lymph nodes taken out, when I take out all the lymph nodes under the arm, I find 35, 40 lymph nodes. So 4 lymph nodes is a small number, and most of those women, only around 5% of those women will get lymphedema.
Dr. Kesmadal, we're going to keep you here because we had another one sent in just now. I've had lymphedema for 10 years, and it's hard to forget about my original diagnosis. The swelling is under the breast area. What interventions are recommended?
So we typically start when we have mild lymphedema with non-operative interventions. This, if it's on the arm, we recommend wearing a sleeve, which I know for some women can get uncomfortable, and particularly here in Miami, it's very hot. So sometimes these sleeves are quite uncomfortable, but that is a non-operative option. And then massage therapy. So those are the main 2 non-operative options. That massage therapy can be delivered by a trained lymphedema therapist, or sometimes we have home units that can be utilized where a patient will have massage every day. But as you can imagine, it can be quite a difficult process. You have to manage it every single day. So if we have patients who have not responded adequately to those non-operative interventions, that's when we go into the more advanced surgical techniques. And again, these are newer techniques, and we don't know all of the, we don't have as much data on them as we would like, but we're starting to gain more and more data that for women where these non-operative interventions are not successful, that these operative interventions may be successful and may liberate some of these women from these sleeves and these massage sessions or massage devices that are required at home. And hopefully with more time, we actually currently at Sylvester, we actually have a comprehensive lymphedema program where we have some of our physicians who do rehabilitation medicine, and some of our physicians who are involved in plastic surgery and reconstruction who have developed this comprehensive lymphedema program. And hopefully over time, we'll gain more information on the efficacy of these surgical interventions and potentially help more women who really have significant lymphedema.
Great, thank you so much. And Dr. Perez, another one just sent in. We are getting a lot of questions sent in. We thank you so much. We promise we're going to get to as many as we can. Is there a point as a survivor that you can take a deep breath and know that you are fairly safe from a recurrence? And what % of people have a recurrence?
Yes. So we look at the type of tumor. So we know, for example, that tumors that are aggressive by nature, let's say triple negative breast cancer or HER2 positive tumors, they usually recur. If they're going to recur, they usually recur quickly. So it could be in the first 2, 3, 4 years. Tumors that are estrogen positive, progesterone positive, so hormone positive tumors are usually more slow growing tumors. And those ones can recur late. So unfortunately, we see recurrences 10 years later, 15 years later. We have to remember that most of the women that we treat are cured. So the risk of recurrence is low. But of course, it depends on stage. And that's why we make such a big emphasis on early detection. Because we know that if we diagnose the case very early, chances of being cured, obviously, they go up. So it depends on staging. It depends on the type of the tumor. So if I have, let's say I have a patient that has a triple negative breast cancer or a HER2 positive breast cancer, that will be rare for that patient to recur after 5 years. But let's say I have a patient that is estrogen positive, those patients I'm going to pay attention for life, and patients stay with us for pretty much for life. So again, it depends on the staging and it depends on the type of the tumor. But remember, most patients are cured, and that's the good news. And the other good news is that in the last 30 years, we have decreased mortality from breast cancer by 40%. So we've made a significant amount of progress in the last few decades, and that's also thanks to early detection and to the new therapies that we have.
That's amazing, the 40%, and the cured part is even perfect. We're going to keep you here because this one just followed up. This past Saturday, the Sun Sentinel had an article about a breast cancer vaccine. What can you tell us about this vaccine?
Yes, so vaccines are very popular nowadays. We're doing a lot of clinical trials on vaccines all over the country. Vaccines, these are a form of immunotherapy, and immunotherapy, pretty much the rationale behind it is that we stimulate our own immune system to attack cancer cells. So it sounds, very promising, but of course we have to test the concept to make sure it works. At Sylvester, we have been involved with 2 different types of vaccines. We had a clinical trial for patients with triple negative breast cancer that completed their treatment. And at the end of the treatment with triple negative, you don't do hormonal therapy for 5 to 10 years like we do for some other cases. So once you finish the treatment for triple negative, most patients say, now what else can I do? So we tested this vaccine for patients that completed treatment and they received the vaccine for 2 years. This study already closed and we're waiting to analyze the data. Now we have a study that is open at Sylvester that is for patients that have advanced breast cancer, metastatic breast cancer. And we're giving this vaccine, again, a form of immunotherapy to see if we can control the cancer that way. So so these vaccines are in clinical trials. We don't have a vaccine already approved for breast cancer. It's work in progress, and at Sylvester we are testing this concept.
Great, Trish, thank you so much. Trish, let's bring you back in. How did the treatment team factor into your experience?
I love my treatment team, and the support that I receive from my treatment team, it also helps me to remain positive. And for example, my treatment team now, Tony, I like to build relationships. So when I'm at Sylvester, one, it does remind me that I have cancer, but once I'm there, I am speaking to the nurses. I am speaking to the people that, you know, when I walk through the front door and I'm greeted, I want to know about them in their personal life. And I'm not treated as a patient. I am treated as a person. I know that my oncologist is Dr. Kalfa. I know that when I see Dr. Kalfa, when she walks into that room, she's going to open her arms and there's a big hug for me. So all of the treatment team, it makes dealing with the cancer and being at Sylvester for treatment, it makes it all easier because they are there for you.
I so well put, and I bet. Dr. Moreno, we're going to bring you back in. And if you want to weigh in on what Trish said, that's fine. But here's your question. Is there a correlation between emotional health and staying cancer-free?
Yeah, I'll say that it's so important what Trish said about feeling like she is being met as a person before being sort of considered a cancer patient or a cancer survivor, because there's so much more to Trish than just this experience, even though, like I said, this experience is defining and important and brings a lot of sort of challenges along with it. Is there a correlation? You know, yes, there has been some research in this area, but I would say it's really important to not get too caught up in that. And the reason I say that is because it is a stressful experience. And the last thing we want to do is add to that stress by you having this sort of unrealistic expectation that you're not going to worry sometimes and that it's not going to impact your mood sometimes. The studies that have been done, there's a silver lining here. They focus on women and individuals, men too, that have very high levels of distress. So they have what we would say are even diagnosable disorders of anxiety or depression. And the really good news about that is that we know that those are very treatable experiences, and that there are things that we can do to prevent someone from ever even getting to that level of distress. And so I would flip that question and say, feel empowered in knowing that there are things that we can do to help you manage this experience. Some stress is inevitable. Don't beat yourself up or have some expectation that you need to transcend this experience and be positive all the time and be happy all the time and never feel the impact of the losses and the challenges. And with that said, we can prevent anyone from getting too distressed. And that's what the real concern is when we think about whether or not there would be an association with outcomes in the longer term. And so, again, it goes back to making sure that you're trying to take care of yourself as well as possible, and also knowing that there are resources. There are some of us who specialize in helping you manage your emotional health so that you never get to the point of having that sort of severe level of distress that can really get in the way of your quality of life.
Yeah, I bet it could. Great information. Fabulous. Dr. Kesbadal, chemotherapy, this just came in. Chemotherapy reduced my cancer on my one lymph node significantly, but they still removed all the lymph nodules. Is this normal?
So it really depends on the type of cancer and how good the response to chemotherapy is. So as Dr. Perez has mentioned, we have different types of cancer. Triple negative, which is a very aggressive type of cancer, HER2 positive, and then estrogen receptor positive. And each of those cancers responds differently to chemotherapy or systemic therapy. For example, with HER2 tumors, we frequently can get really fantastic responses to chemotherapy. In fact, with some of them, we see complete eradication of tumor in 60 to 70%. And for triple negative in around 50%. But with estrogen positive tumors, we know that they just don't respond as well to chemotherapy. And they respond very well, most of them respond very well to endocrine therapy. So if we have a patient where the response was not as good as we wanted, we then still remove the lymph nodes, and our imaging studies, unfortunately, are just not sensitive enough for identifying small amounts of disease. So even if the lymph nodes look potentially normal or have decreased in size, we don't know for sure that there's not cancer there. So when we have a positive lymph node and we have certain cancer types, we still have to remove the other lymph nodes when we do surgery. But we're really trying hard to understand how to avoid that, how we can better select our therapies before we do surgery, so that hopefully when we get to surgery, no woman has to have the lymph nodes removed or only can have a few lymph nodes removed. But we haven't gotten to that point yet.
Thank you, Doctor. Dr. Perez, again, this one coming in. I just finished 12 cycles of immunotherapy and paclitaxel. I hope I've said that right. And now I have severe neuropathy in the hands and feet. I'm a medical technologist and I need my hands to work well. What advice do you give to improve the neuropathy?
Yes, unfortunately, that's a side effect of especially the taxanes. And you're saying that you just finished the treatment. So of course, give it some time, because some of those side effects will go away. Some women end up with neuropathy, and we have medications that we can use. There are different types of medications. There's something called gabapentin, there's Cymbalta, there are different types of medications that we can use. Acupuncture sometimes is helpful in some cases. We recommend exercise that can also help us with neuropathy. Sometimes having an evaluation by a neurologist can help us. They can give us other tips, finding other reasons why neuropathy is worse. There are other risk factors for neuropathy, like diabetes or alcohol, or there are many other factors that can contribute. So something to discuss with your physician, because there's medical therapy, and again, exercise and acupuncture. There are some other things that you can do.
Great. Thank you, Dr. Perez. Dr. Moreno, another one that just came into us. In line with survivorship support, there is a strong correlation with body fat composition in cancer. Is anything being done to help support weight management with pharmacological intervention?
Well, I'll let Dr. Perez talk about pharmacological interventions. I will say there's been a lot of research in healthy weight management through exercise and through nutrition, particularly diets that are a little bit more plant forward. So really focus on a lot of vegetables and fruits, kind of like the Mediterranean diet. But in terms of pharmacological interventions, I think that Dr. Perez could talk about whether there's any research in that area. I've mostly seen more behavioral interventions in this area, particularly among women with breast cancer.
Yeah, we know so much about being overweight and obesity, the risk factors for breast cancer, not just to have breast cancer for the first time, but also you can have an increased risk of a recurrence if you're overweight. So we pay a lot of attention to that, and lifestyle changes are key. What we want to do is not just a diet to lose the weight, it's a lifestyle change. It's something that is sustainable. And the problem with those pharmacological interventions is that you're not going to do them for life. So yeah, some of them are effective. Where there are different ones that sometimes patients use. But again, I'm pretty much against those, because we don't want a quick fix. We see that those patients that use those pharmacological interventions, sometimes they lose the weight, but a few months later they put it back on. So I think it's very important to really change your lifestyle to something that is sustainable, that you're going to do for the rest of your life, so you can keep the weight down that way. We do work with weight management specialists here at Sylvester, and they use those medications, and so there's nothing wrong with that. You can use them for a short amount of time, but again, very important to do something that is going to be sustainable. So at the same time, you start changing your lifestyle, so you can continue to do that for the rest of your life.
Yeah, well said, Doctor. Sustainable is the key word there for sure. Dr. Kesmadov, this just came in. This involves invasive lobular carcinoma. Is the treatment different than ductal, and how do the approaches differ?
So invasive lobular carcinoma is the second most common type of breast cancer that we see. Ductal is the most common, but really stage for stage, the cancers are treated very similarly. We look at the tumor characteristics, and then depending on the extent of disease, we decide whether we are going to start with surgery first, whether we're going to start with some other type of treatment first. Frequently for lobular cancers, we will do surgery first because many of them are estrogen receptor positive, and those tumors don't respond to chemotherapy as well. The one thing I'll say about lobular cancers is that they are much harder to identify. They're more subtle on imaging because of the way they grow. They don't typically grow as a mass. They grow as small cells separated in the breast tissue. So you can imagine that it would take longer for us to see that kind of disease on mammography or ultrasound. So we do frequently see patients coming in with lobular cancers with more advanced disease. However, with some of our newer imaging technologies, for example, we have tomosynthesis, which is a mammogram where you take slices at different angles in the breast and then put them together into an image that you can kind of see the breast tissue going in and out in slices. And with that technology, we are able to see some of these more subtle findings. And of course, breast MRI is another useful study, which we use in high-risk patients. But I would say stage for stage, we do currently treat lobular cancers very similarly to how we treat ductal cancers.
Thank you, Doctor. Dr. Perez, what does targeted therapy involve? That was just sent to us.
Yeah, so if we compare, for example, to chemotherapy, we know that when we give chemotherapy, chemo doesn't discriminate. It kills good and bad cancer cells and also good cells, and that's why we have more side effects. Targeted therapy only kills the cancer cells. So, for example, the most common example I can give you of targeted therapy is the HER2 drugs that we have. So we know that 15 to 20% of tumors are HER2 positive. So when we have that target, the HER2 gene or the HER2 protein, we can give a medication that will only kill those cancer cells that express the HER2 protein. And that's the most common type of targeted therapy. Hormonal therapy, in a way, is also a targeted therapy. You have a tumor that is estrogen positive, and you're giving a medication that will block the estrogen receptor. So there are different forms of targeted therapy. They're usually, very specific for certain kinds of tumors, and most of them are very well tolerated because, again, we spared a lot of the good cells from dying with the treatment.
Great, thank you so much, Dr. Moreno. Another one. The questions just keep pouring in. I need to know, where can I find information of a support group and therapy services? I am newly diagnosed.
Well, we certainly have those resources at Sylvester. And if you just Google Sylvester Cancer Support, they will come right up, and there are different support groups here at our cancer center. And then sometimes there are some in the community as well. So depending on where you live, there might be a resource near you. And so I would say one of the best places to start is with your team, just because they are treating a lot of women like you. And so they will know what has worked well for a lot of their patients. But certainly at Sylvester Cancer Center, we have those resources.
Great. Thank you, Dr. Moreno. Patricia, we haven't forgotten about you, honey. Do you have any advice for mentally getting through the treatment process?
My advice is as I indicated earlier, to work with your team, work with your family, and basically it's a matter of what your personality is. As Dr. Marino said, there are support groups. So you know yourself, and to thine own self be true. And basically what you need, make it a point to try to put that in place for you.
Great, thank you. Dr. Perez, how long should a survivor follow up with an oncologist after treatment? And can follow-up imaging be transferred to a primary physician?
Yes, so it depends on the doctor and it depends on the patient. Us at Sylvester, we like to follow patients for life. I think it's important, you have that connection with the patient. They feel comfortable with you. They feel safe, right? And so we like to follow those patients for life. Some doctors can discharge the patient maybe after 5 years, 10 years. So it depends. Also, it's the patient's preference. Let's say the patient has a very good primary care physician and they have a great relationship with them. They can also continue follow-up with them. So it depends. And also the type of tumor, the staging, how careful you have to be with the follow-up. What do you think is the likelihood of recurrence? Some patients have very small tumors. They can go back to their primary care physician. So it's a team effort. And we work together with primary care physicians. And again, the patient decides if they want to stay with us for life or not.
Great. Thank you so much, Doctor. Dr. Kesbadal, another one that just sent in, I was diagnosed with stage 1 in 2008. I took preventative medication for 5 years and I chose to stop treatment at that time. What preventative options are available to me at this time?
So typically in women with early stage breast cancer, and I assume it was estrogen receptor positive, and that the 5 years of medication was a medication which would reduce estrogen production or the effects of estrogen in the body. So at that point, we typically will continue that for 5 years. And then, as Dr. Perez mentioned, we will continue to follow that patient. Here we do that for life, or we work in conjunction with the patient's primary care doctor or their GYN. At this point, I would say that lifestyle, being healthy is the most important thing. I stress this for all of my patients. And I also say moderation. I'm not someone that wants to eliminate things from everyone's diet, or go on an exercise routine where you have to exercise 3 hours a day. As Dr. Perez, we want lifestyle modification and sustainability. I always tell patients to think about what they're eating. I think we all know what a healthy diet looks like. It's fruits and vegetables and maybe some lean proteins and not too many things from a box. And I tell patients to stay active and involved. So exercise is extremely important. It's not just important for breast cancer, it's important for cardiovascular disease. So I think maintaining a healthy weight, being active, and then I always want my patients to be connected to the things that are important to them. Their family, the activities, if work is important to them, make sure that they still work. So I think those are the things that I think keep you healthy. And we know that stress management is helpful. So, for some people that's being with family and friends, for some people that's exercise, for some people that's meditation. But these are the things I tell my patients to do.
Yeah, well, it's interesting because we just had this question sent into us, and maybe the last one we get to tonight. For Dr. Perez, any advice on any food to avoid when I'm diagnosed with cancer?
So what I always say to my patients is you eat the food that is going to keep your weight down. Keeping your ideal weight is so important in the management of breast cancer. So of course we're going to avoid all the carbs and trying to, or fatty foods, or we have to follow a healthy diet. Whatever we need to do to keep your weight down is really the diet that we have to follow. So of course that's going to look different to different patients, but that's the key. Keep an ideal body weight.
Thank you, Dr. Perez. And Patricia, I'm going to end this on you with something just from me. Can you just give us some sage wisdom, especially those who maybe were just diagnosed, someone who's still going through this? Any last words before we leave tonight?
When you said wisdom, Tony, I'm like, oh my God, wisdom. I continue to say to try to maintain a positive attitude. I agree with what Dr. Susan just indicated. If you enjoy work, then continue to work. If you enjoy meditation, you know, like I said earlier, to thine own self be true. And what works for me might not work for someone else. So, you know, to thine own self be true, and to think about it. But for me, I don't want cancer to control my life. So I want cancer to have about this much of my time, and my life to have everything else, and to not revolve around it. But if someone else might have a different approach. So I still say, try to maintain positivity. If that means speaking with a therapist, if it means medication, if it means a support group, whatever works for you as an individual, try to make sure that the focus on other activities in your life control, as opposed to the cancer.
Well said. God bless you. It was such an honor to have you tonight, and Dr. Perez and Dr. Kesbadal and Dr. Moreno. What an amazing evening. Not only was it informative, but I hope you agree with me, those of you watching, equally insightful and heartfelt by a survivor and an amazing team of passionate and talented doctors. I don't know about you, I could stay here all night and listen to our panelists. How blessed are we to have them at Sylvester and our entire university health system? Quite a night. Thank you for participating in tonight's town hall and In the Know. Please remember that a full recording of this program will be posted online. Look for the link in coming days. And then in a moment, you'll also see a survey about tonight's town hall on your screen. Please take it. It takes about 25 seconds, maybe, because what that does is when you submit your feedback, it helps us understand your interest and helps us improve our program. As always, we wish you and your family nothing but good health and a good night. And from all of us, remember, it's all about the you.